Today's speakers are Dr. Shailesh Pitale. Dr. Shailesh is endocrinologist and Director-in-Chief of Endocrinology at DU Medical and Trinity Hospital in Nagpur. I welcome Dr. Shailesh in this expert web talk.
Thank you.
Welcome, sir. Our next speaker is Dr. Rishi Lohiya. Dr. Rishi is a Consultant Interventional Cardiologist at Alexis Multispecialty Hospital in Nagpur. I welcome Dr. Rishi in this expert web talk, and I'm handing over the session to Dr. Shailesh to start with the presentation. Thank you.
Good evening, everyone, and thank you, Shovik, and the whole Lupin team for this evening session. And as was rightly mentioned, now, apart from treating only the blood sugars, we clinicians are concerned about the cardiovascular aspects of our diabetic patients because the diabetic patients are at extremely high risk of having cardiovascular problems. And these newer drugs, SGLT2 inhibitors, have brought diabetologists, endocrinologists, and cardiologists quite close because of the benefits that these drugs share. So, courtesy SGLT2 inhibitors, endocrinologists and cardiologists have become close friends now because these drugs help us to reduce the cardiologic risks of our patients, cardiovascular risks of our patients. So, we'll be looking at the cardiovascular risk in our diabetic patients. So we know that despite multiple therapies, majority of type 2 diabetic patients are uncontrolled. We have a lot of diabetic therapies for type 2 diabetes available. Many new anti-diabetic drugs have come, but in spite of that, good number of patients have high HbA1cs. Globally, it's been shown that about 27% of patients with type 2 diabetes have HbA1cs more than 9%. Now, if you look at the natural history of diabetes, we know that when diabetes is diagnosed, by that time, more than 50% of the beta cells are already lost. So, good number of patients already have lost their beta cells. So, the older therapies, in terms of sulfonylureas, which we commonly have been using for decades together, we know that they work through beta cells. So, these already when the beta cells are 50% gone, these do not work as well. And the newer drugs, which are independent of beta cell function, they work, have a glycemic benefits independent of beta cell, are the ones which are beneficial. Let's look at this patient, Mr. Rajesh, who is a corporate executive, non-smoker, who is 45 years of age, having diabetes for 2 years, hypertension for 6 years. He is on metformin 1 gram twice daily and telmisartan 40 milligrams once daily. His HbA1c is 8.8. So here we have a gentleman who is 45 years of age, corporate executive, most likely work stress high. He has cardiovascular risks in terms of diabetes, hypertension. He is obese. So this puts him at a very high risk of having cardiovascular event in future. So what should be the approach for this particular gentleman? So one would be, should it definitely glycemic control, and he is working as a corporate executive. We know that corporate executives have very hectic lifestyle. So risk of hypoglycemia also needs to be reduced in such individuals. So we need to choose an anti-diabetic agent where the risk of hypoglycemia is less, which would control both fasting post-meal as well as HbA1c. And on top of it, we have seen that this guy has a high cardiovascular risk in terms of being a diabetic, hypertensive, and also obese. So he has got significant cardiovascular risk. So we should look at a drug which would help reduce the cardiovascular events in this particular patient. So when you look at the pathophysiology of type 2 diabetes, the ominous octet we know. So I'm not going to go into the details of this, but we know that hyperglycemia is caused by many actions or many pathophysiological defects, and the various drugs which we have available, the oral antidiabetic agents, work at different levels of this pathophysiological parameters which are deranged in diabetics. So considering SGLT2 inhibitors in particular, they do help in terms of they help in decreasing the glucose uptake by increasing the glucose uptake by the peripheral tissue. They cause renal excretion of glucose, which reduces, which causes glucosuria and reduces the blood glucose. They have an indirect effect on the beta cells and help to improve the beta cell function in diabetics. So when you look at this capture study, a cross-sectional study of contemporary prevalence of cardiovascular disease in adults with type 2 diabetes across 13 countries, the study found that 1/3 of people with type 2 diabetes have established cardiovascular disease. And 2 out of 3 deaths in diabetics are due to cardiovascular disease. So out of the deaths in diabetic patients, 2/3 of deaths are due to cardiovascular events. So the lifetime risk of patients dying due to cardiovascular problem in diabetic population is quite high. So if we can reduce this cardiovascular risk, that helps us. So when we look at the expectation of newer anti-diabetic drugs, we are looking at, apart from glycemic control, we would want the cardiovascular risk to be reduced in these patients. So when you look at the cardiovascular risk in diabetic patients, the Firming Heart study, they showed that the high rate of heart failure in patients with diabetes over 30 years of follow-up. So when you look at these patients, the Firming Heart study, it showed that both in men as well as women, the risk of heart failure, cardiac failure was quite high in both men as well as women over a long period of time. Apart from that, the risk of intermittent claudication was high in women with diabetes. But looking at the cardiovascular risk of heart failure, we would definitely want this Firming Heart study, which was this study was published way back in 1992. Before the SGLT2 inhibitors were there, it showed that the risk of type 2 diabetic patients having heart failure is high. Now, the MRFIT study, the impact of diabetes on cardiovascular mortality, if you look at the number of risk factors, if they are there in patients who are non-diabetics versus diabetics, what is the risk of mortality, risk of these patients who are diabetics or non-diabetics? So when you look at the CV risk, and if the pink bars are for diabetic patients and the green bars are for non-diabetics. So if you look at those with diabetics, if they have the risk factors 2 or more, the risk of having cardiovascular mortality is very high. So our patient in question, who is a 45-year-old gentleman, has 2 risk factors apart from diabetes. So his risk of cardiovascular mortality is quite high. Another important thing is delay in intensification by 1 year in conjunction with poor glycemic control. This significantly increases the risk of myocardial infarction, heart failure, stroke, and composite cardiovascular endpoints. So this is a retrospective cohort study of more than 1 lakh patients in type 2 diabetes using the United Kingdom Clinical Practice data link from 1990 with a follow-up data up to 2012. And it found that there is increased risk by about 67% of risk of MI if there is 1 year delay in receiving the intensification of treatment. Similarly, risk of stroke is increased, risk of heart failure is increased, risk of CVE is increased, and this increases by about almost 60% or more than 60%. So when you look at type 2 diabetes and cardiovascular disease, the studies which were done earlier, which tried to look at this correlation between type 2 diabetes and cardiovascular disease, the UK-PDS, DCCT, and the proactive study, they did show that in UK-PDS, for every 1% reduction in HbA1c, there was a significant reduction in the microvascular complications in terms of 37% reduction in microvascular complication, but also there's 14% decrease in the fatal and non-fatal MI, and also stroke, but and also heart failure. But the benefit of microvascular complications was more as compared to macrovascular complications. Same in DCCT, it reduced significantly the risk of microvascular complication in terms of retinopathy, but also the risk of cardiovascular deaths and non-fatal MI was reduced. Similarly, in proactive study, the intensive glycemic control caused reduction in the non-fatal as well as fatal MI and strokes. Now, coming to SGLT2 inhibitors, these are the new group of drugs which we have been using now for last few years, and they have shown promise in terms of reduction in the cardiovascular events. So the SGLT2 inhibitor evidence validates that these drugs which are there, dapagliflozin, which we have since March 2008, canagliflozin, remogliflozin, empagliflozin, these are the drugs which have been shown to have significant cardiovascular benefits. And these have now found their place in the guidelines for diabetes treatment. The European Society for Cardiology and European Association for Study of Diabetes guidelines of 2019, if you see that the recommendations do say that for glucose lowering treatment for patients with diabetes, SGLT2 inhibitors like empagliflozin, canagliflozin, dapagliflozin, they are recommended in patients with type 2 diabetes and having cardiovascular disease, or those who have very high risk or high risk of cardiovascular disease. So those who have significant risk factors and are having type 2 diabetes, in them gliflozins, empagliflozin has been shown to have significant benefit. So there's a class 1 level A evidence which does show that it helps in lowering the risk of hospitalization due to heart failure in patients with type 2 diabetes. So when you look at the ADA 2020 guidelines, where do SGLT2 inhibitors stand? SGLT2 inhibitors, this group of drugs has really climbed up the ladder in the recommendations of all the international organizations. So ADA does recommend that first line is metformin with lifestyle, but those who have indicators for high risk or established atherosclerotic cardiovascular disease or CKD or heart failure, they should consider independently of baseline HbA1c or individualized A1c target. So earlier guidelines were targeting only the glycemic control, but now looking at the mortality occurring because of cardiovascular events, it has been shown that those who have risk for atherosclerotic cardiovascular disease or CKD, in them one would consider SGLT2 inhibitors way above in the recommendations that SGLT2 inhibitors are recommended by the ADA now. So prevention with empagliflozin, the EASD, ADA, the American College of Cardiology, American Heart Association, if you look at these recommendations, the EASD, ADA consensus recommendations do recommend that for management of hyperglycemia in type 2 diabetes, if they have atherosclerotic cardiovascular disease or have history of heart failure, it is better to start SGLT2 inhibitor like empagliflozin that is beneficial in these patients. Same with American College of Cardiology consensus recommendations. If you see your ACC and AHA guidelines for primary prevention of CVD, one would look at the cardiovascular clinical settings, and if the cardiovascular risks are high, in them one would consider either SGLT2 inhibitor or GLP-1 receptor agonist, which could be either started with the European Society recommends that you could start with that as a monotherapy also, or as per ADA or American College of Cardiology, that SGLT2 inhibitors could be an add-on to metformin. Now, when you look at empagliflozin, what are the mechanisms which are responsible for the cardiovascular benefits? It's been shown that the myocardial energetics are better. There is a preload reduction because of the diuresis. There is an afterload reduction because of the BP reduction. These patients have a reduction of hyperuricemia which occurs. There is increase in the hematocrit which occurs in these patients. There is cardiovascular remodeling, improvement in the insulin resistance which occurs, prevention of NT-proBNP increase, and there is increase in adipokine levels. There is increase in circulating provascular progenitor cells which are seen, and all these mechanisms. Also, there is one interesting thing which has been shown with SGLT2 inhibitors, that it causes a reduction in the epicardial fat pad, and epicardial fat pad has been shown nowadays to be having pathophysiological contribution towards occurrence of cardiovascular disease in diabetics and even in non-diabetics. So when you look at the EMPA-REG outcome, the cardiovascular outcomes which are seen, this was a study of where more than 11,500 patients were screened, 7,000 patients were randomized, and more than 97% completed the trial. Patients were with type 2 diabetes at high cardiovascular risks. They were randomized either to placebo or to empagliflozin 10 milligram or empagliflozin 25 milligram, and this was an add-on to standard of care treatment. So when you look at the CV outcomes, it significantly reduced the risk of heart failure, cardiovascular death, all-cause mortality, and the 3-point MACE, which was significantly reduced. There was improvement in the renal outcomes also in terms of albuminuria, which was better. There was improvement in the renal parameters in these patients. So when you look at the CVOT trials of SGLT2 inhibitors, the EMPA-REG trial or the CANVAS trial or the DECLARE-TIMI trial, empagliflozin was the only drug and EMPA-REG was the only trial where it showed benefit in terms of statistically significant benefit in terms of hospitalization due to heart failure, cardiovascular death, and 3-point MACE. All the three were significantly reduced in those patients who received empagliflozin. While in the CANVAS trial with canagliflozin, the hospitalization due to heart failure was reduced, but CV deaths came down, but it was not statistically significant. The 3-point MACE was less. With DECLARE-TIMI trial also, there was a reduction in the heart failure, hospitalization due to heart failure, but the CV death benefit and the 3-point MACE benefit was not statistically significant. The major adverse cardiac event risk reduction with SGLT2 inhibitors in patients with type 2 diabetes, the CVOT study, if you see, again, empagliflozin is the only SGLT2 inhibitor which offers consistent reduction in the major adverse cardiac events, which was seen with empagliflozin as compared to the other trials which are listed here. So empagliflozin caused significant reduction in the 3-point MACE, which was seen very clearly in these trials. The cardiovascular death risk reduction with SGLT2 inhibitor in type 2 diabetes CVOT also, there is decreased risk of cardiovascular death in atherosclerotic cardiovascular heart disease patients driven by only empagliflozin. So in this particular group also, those who had established atherosclerotic heart disease patients, in them empagliflozin significantly reduced the risk of death in these particular patients, and there was significant mortality benefit seen in those patients who received empagliflozin. So when you compare empagliflozin with the DPP4 inhibitors, we know that DPP4 inhibitors have been one of the designer drugs which have been available to we clinicians for last few years. So when you compare the efficacy of empagliflozin with DPP4 inhibitor, the effective glycemic management and cardiovascular protection, if you compare, the glycemic benefits are almost similar, slightly better with empagliflozin, the HbA1c reduction as compared to sitagliptin. But when you look at the cardiovascular protection, there is a significant cardiovascular protection in terms of 41% lesser hospitalization due to heart failure and 48% lesser risk of mortality in those who received empagliflozin as compared to sita. So empagliflozin, it's effective in glycemic management as well as cardiovascular protection when you compare it with sitagliptin. We know that the sitagliptin cardiovascular outcome trial, the TACOS trial, did not show that there was any increase in the cardiovascular risk with sitagliptin, but it did not show any benefit of sitagliptin in terms of cardiovascular events, while empagliflozin significantly has shown a reduction in the cardiovascular death, reduction in all-cause mortality, and hospitalization due to heart failure. And this is endorsed by more than 80 guidelines worldwide for its cardiovascular benefits. So what is new about EMPA-REG? In patients with type 2 diabetes and atherosclerotic cardiovascular disease, the EMPA-REG outcome 1, there's a meaningful, early and sustained decrease in the cardiovascular risk, cardiovascular death. So there was about 38% relative risk reduction in the cardiovascular death in the group which received empagliflozin as compared to the placebo group. So this was very significant over a period of time. So in fact, empagliflozin is a drug where the cardiovascular benefits have, and that's why the recommendation guidelines have now changed, and it is not glucose-centric only. It has now geared towards looking at the cardiovascular risk and then classifying the patients and choosing the drug. There are early mortality benefits in patients with atherosclerotic cardiovascular disease and type 2 diabetic patients. Time to CV death with empiric outcome, if you see. But again, there was a benefit in terms of time to cardiovascular death was, better, favorable in terms of patients who received empagliflozin. Now, empagliflozin demonstrated consistent reduction of incident or worsening nephropathy. So these patients who were treated with empagliflozin also showed there was a improvement in the renal parameters of these patients. There was improvement in the nephropathy in these patients who received empagliflozin. In those who were at low risk, moderate risk, high risk, or across the board, there was a significant benefit in terms of renal parameters also. Now, empagliflozin delays the need for insulin initiation in type 2 diabetes and CVD patients. Now, this was a pooled analysis of findings from the empiric outcome. And insulin in type 2 diabetes, we know, is associated with risk of hypoglycemia, weight gain. It requires the patient to be trained to take insulin. Expensive, one has to, I would sort of, this is a relative term in terms of SGLT2 inhibitors are also not very pocket friendly. So we need to, this is a relative term, but there definitely risk of hypoglycemia, weight gain, and it's not preferred by the patients. So treatment effects of EMPA on time to new initiation of insulin among insulin naive and time which was seen to insulin intensification was also seen. In 52% of insulin-naive patients, empagliflozin reduced the need for insulin use by 54%. And in 48% patients using insulin, empagliflozin reduced the need for increase in the insulin dose. So definitely the dose of insulin and the requirement of insulin was reduced in patients who were treated with empagliflozin. So empagliflozin delays the need for insulin initiation in patients with type 2 diabetes and CVD. And this, again, we know that in a country like ours, where storage of insulin and all could also be a challenge in some patients, if we can delay the onset or we can delay the requirement of insulin in such patients, that would be a welcome thing for our patients. Again, the early mortality benefits in patients with atherosclerotic cardiovascular disease and type 2 diabetes, time to death with empiric outcome. Again, this showed a benefit in the empagliflozin group in this particular trial. Now, the empagliflozin is the preferred one SGLT2 inhibitor in the cardiovascular outcome trial. If you look at empiric trial, it looked at the 3-point MACE and the cardiovascular mortality and hospitalization due to heart failure. And all these three were better, or rather patients on empagliflozin fared better on these three accounts as compared to CANVAS and DECLARE-TIMI and VERTIS trial, where it was predominantly hospitalization due to heart failure, which was benefited. Yes, so if you look at the lower table, it clearly shows that in the clinical trials, the empiric trial, there was a reduction in the 3-point MACE, the cardiovascular mortality and hospitalization due to heart failure, while with the CANVAS trial, the canagliflozin, patients who received canagliflozin, the 3-point MACE and hospitalization due to heart failure were reduced, but cardiovascular mortality was not reduced. Similarly, with dapagliflozin and vertigliflozin, then DECLARE-TIMI and VERTIS trial, only hospitalization due to heart failure was benefited. So to summarize, every 1 in 3 diabetes has established cardiovascular disease, where risk for cardiovascular events are 2 times. Screening for cardiovascular through defined risk scores would be an important step to select proper anti-diabetic therapy with proven cardiovascular benefits. So apart from glycemic benefits, we should be looking at cardiovascular benefits because our diabetic patients are at a higher cardiovascular risk. Empagliflozin is the only oral anti-diabetic agent which offers cardiovascular death as well as all-cause death benefit to the patients along with better glycemic control. Empagliflozin also offers consistent reduction for incident or worsening of nephropathy in all categories of renal insufficiency in diabetic patients. And empagliflozin is an ideal choice as first add-on in type 2 diabetes in patients with cardiovascular risk over other agents because of the significant cardiovascular benefits. And in fact, we were just discussing in another meeting the other day that maybe a point may come where, and we know that our cardiologist friends are using SGLT2 inhibitors for more of cardiac benefits, and maybe these drugs will be used more for cardiac in even in non-diabetic patients in future, if they, as the data which is showing now. So with this, I would like to stop here. Thank you very much for your kind attention. And I'm sure Rishi is going to discuss about the cardiological perspectives of empagliflozin. Thank you very much.
Thank you, Dr. Shailesh. Dr. Rishi, you can start the presentation.
Good evening, all of you. Congratulations, sir, for that wonderful talk. You have already set the ball rolling, and probably now it will be very easy for me to build up on the basics what sir has already discussed. So, as we were discussing, that whenever we have diabetes, it is already implied that patient has got some subclinical cardiovascular endothelial disorder. Now, as a cardiologist or as a treating physician or endocrinologist, our aim is always to control sugars, but at the same time try to understand the subclinical cardiovascular disease severity and accordingly classify the patient into different risk categories and treat him accordingly. We all know whenever a patient is diagnosed with diabetes, the total life expectancy significantly goes down, and a major responsible factor for it is a cardiovascular comorbidity or occurrence of cardiovascular complication. Now, if we look at the data that was obtained from CURE study, wherein Asian Indians were evaluated for the overall death, the death due to ischemic heart disease and cerebrovascular deaths, it was found that as compared to non-diabetic, the occurrence of death and the cardiovascular deaths was significantly higher in diabetic group as compared to non-diabetic. Similarly, if we look at our data and compare it with global data from different races and different countries, ethnicities, you all will agree that we Indians and especially Southeast Asians have got higher mortality because of early onset of diabetes. We are more lipidogenic, we have higher triglyceride levels, we are short and stout. The occurrence of cardiovascular complications occur almost a decade earlier than the Western population, and long-term outcomes are also poorer as compared to our fellow humans from the other part of the world. So in total, we have to be more vigilant about the cardiovascular complications whenever we are dealing with patients with type 2 diabetes. Now, there had been multiple assessment algorithms so as to understand the risk, to decide if patient has got increased risk of occurrence of cardiovascular disorder in the diabetic subset. So we know the 2014 ACC guideline for cholesterol management. They had come up first with this ASCVD risk calculator, and it was said that if the risk is more than 7.5% over next 10 years, patient needs to be treated more aggressively with statins and aggressive diabetes control. Similarly, we have different lab tests and different investigations like treadmill test, which was very commonly used a decade back, but now many of the guidelines not recommended for diagnosis of atherosclerotic cardiovascular disease. Then CT calcium, the coronary calcium score, which is now being commonly used, and we all know whenever patient is diabetic and has got high calcium score, the risk of subclinical cardiovascular disorder is high. Then the other non-invasive tests like myocardial perfusion scan or stress echocardiography, they are being used more and more commonly so as to find out patients who are asymptomatic and diabetic with multiple risk factors. So ultimate aim is to diagnose, pick up the patients before they get a coronary event or cardiovascular event and treat them in such a way so that we can prevent the occurrence of first cardiovascular event. Now, this is the score which is now being used very commonly. It has been validated in some of the recent trials, and this is risk score model wherein the authors have tried to incorporate multiple risk factors. We all know there is no direct cause-effect relationship. If at all we have to find out one cause for atherosclerosis, and there have been multiple risk factors, those have been identified. So depending upon the propensity of each of the risk factor, this score has been designed. It consists of age, gender, duration of diabetes, hypertension, smoking status, family history of premature atherosclerosis, history of stroke, then the ratio of total cholesterol to HDL, and then evidence of neuropathy. So if we calculate this score, and if at all the score is more than 4, then patient falls into moderate risk, and if it is more than 7, then patient is categorized as high risk group. Now, intermediate and high risk group are the groups which probably have got more probability of having a clinical or subclinical coronary artery disease, and these are the patients who need to be treated aggressively so as to prevent the first event. Now, you all will agree with me if at all we try to analyze the data from the HbA1c and occurrence of cardiovascular complications. The poorer the HbA1c or the glycemic control, the increase in the occurrence of cardiovascular complications, the occurrence of first event, and the long-term outcomes. So naturally, our aim in diabetes management is to control diabetes and the glycemia, and at the same time also have the super added advantage of the some of the newer molecules so as to prevent the atherosclerotic and heart failure complications. Now, earlier the glycemia is controlled, better is the long-term outcome. If you look at this graph as compared to the upper curve, if you look at the lower curve, when the glycemic control was achieved within first 6 months after the onset of therapy, irrespective of the HbA1c at the beginning of the treatment, the mortality benefit was significantly more in the group which achieved early glycemic control as compared to delayed glycemic control. Now, if you look at the association of atherosclerotic cardiovascular disease and diabetes, almost 1 in 6 patients do get a major cardiovascular disease, and almost 2 of the 3 patients with congestive heart failure will have diabetes as a comorbidity, and CKD is also very common. So this is all very easily we can explain from the common cell hypothesis, which we all know, and we have been discussing it in our multiple webinars. Now, if we look at the advantage of the prevention of prevention of first cardiovascular event in patients who are at increased risk of atherosclerotic cardiovascular disease, as were enrolled in EMPA-REG outcome. We all know that in EMPA-REG it was found that when patients were treated with empagliflozin as compared to placebo, the separation of curve was as early as first month, and there was sustained increasing benefit, and the total benefit that was achieved was almost to the level of 38% relative risk reduction in cardiovascular death. Now, this is a huge number, because if you ask me, in last 2 decades, there have been handful trials which have shown the mortality benefit of this level in prevention of cardiovascular deaths. So these numbers are very important, and importance is the separation of the curve occurs quite early. So from this, it means that the patients, if rightly initiated on empagliflozin, for the patients who are at increased risk of atherosclerotic cardiovascular disease because of their age, because of their gender, because of past history or smoking habitus, or because of dyslipidemia, these patients definitely will have more benefit as compared to the normal counterparts, and the patients who and the benefit will be seen as early as first month after the onset of the therapy. Now, if we go into the depth of the EMPA-REG data that was achieved, and if we look at the segregation of the data in terms of the coronary anatomies, you will see that when the patients were treated with empagliflozin, the prevention in terms of single vessel, I mean the CV death prevention in different groups, the patients, whether they had a single vessel disease, multi-vessel disease, whether they had undergone a bypass surgery, or if they had a history of myocardial infarction in the past, the benefit was seen in each of the groups. So irrespective of the past baseline characteristic of occurrence of myocardial infarction in the past, or whether patient has undergone any kind of revascularization, the benefit was uniform and in all the subgroups. Similarly, if we look at the other cardiovascular disease prevention benefit in terms of peripheral arterial disease, stroke, heart failure, and atrial fibrillation. So in these categories also, empagliflozin had statistically significant benefit over the placebos. If we look at the sub or the secondary endpoints in terms of fatal myocardial infarction, fatal stroke, heart failure related death, sudden death, or presumed cardiovascular death, again you can see the benefit was seen in all the groups, and the benefit was maximum in the heart failure related death, but it was also seen in the prevention of death due to myocardial infarction and stroke. Now here the data, if we see for empiric outcome versus the other SGLT2 data, here in the empagliflozin has got an edge because in other studies the mortality benefit was not statistically significant as was seen in the empiric outcome. Again, now if we see that the time to cardiovascular death, so again the hazard ratio was significant as early as less than 2 months from the enrollment. So this proves that early usage of SGLT2 inhibitors in diabetic patients who are at risk or who have established atherosclerotic cardiovascular disease, they can definitely be benefited in terms of prevention of the second event, the prevention of first event, and also the cardiovascular death. Now, if we look at the data from the patients who were not having any heart failure at the time of enrollment, or who were not requiring any loop diuretic, and when they were treated with empagliflozin versus placebo, again the benefit was achieved at par with the patients who had heart failure. I mean, the benefit was more prominent in heart failure, but even in patients who did not have heart failure to begin with, even in those subclasses also, the all-cause mortality, the cardiovascular death, occurrence of first heart failure or CVD were low as compared to the placebo, and the differences were statistically significant. So, from this and the other phase 3 trials, if you look at this slide, this is a meta-analysis wherein they have included the other studies except for empiric outcome trial, and there are almost 7 phase 3 studies. Those have been included in this study, in this meta-analysis, and they have found that even in the other studies and this meta-analysis, the occurrence of coronary artery disease, peripheral artery disease, and strokes have been less in the empagliflozin group as compared to the placebo. So now what's new about the empiric? So if we look at the recurrence of the cardiovascular event in patients with type 2 diabetes, you all will agree that it is a pretty common phenomena. We all see that a patient who was diagnosed with a coronary artery disease underwent revascularization either with coronary angioplasty or CABG. They do come back after a few years with recurrence of the event, either because of the development of a newer lesion in the same artery or in the other artery, or they land up with the strokes or peripheral arterial diseases. It is very common. It is really debilitating for the patient, and it is also socioeconomically draining for them. So now, if in such patients, if the empagliflozin is added in patients, these patients from the sub-studies of the empiric outcome, it was clearly found that when patients were treated with empagliflozin as compared to placebo, the occurrence of second event was significantly prevented in such population. Now, if we look at the newer analysis of the same data that was achieved from EMPIRIC outcome trial for the first as well as the recurrence of the cardiovascular event in patients with type 2 diabetes with established heart disease or the cardiovascular disease. It was found that there was significant reduction in the 3P MACE rate, the heart failure occurrence, all-cause hospitalization, fatal or non-fatal myocardial infarction, and even in the occurrence of the recurrence of the coronary artery disease. So these numbers are really significant. Now, sometimes we do feel like the clinical trials are a different ball game because the patients are very stringently followed up and they are strictly followed for their sugars, lipid profiles, and the antiplatelet therapy and everything. So in a way that has got some truth also. So we always try to also look at the post-marketing surveillance or the phase 4 studies, and EMPIRIC's real world evidence is something which talks us about the real world findings. So these are not the patients who were enrolled in the randomized control trial, but these were the patients who were retrospectively analyzed for the benefits those were achieved with empagliflozin as compared to the DPP-4 inhibitor. And you'll see that almost 78,000 patients were evaluated in EMPIRIC's real-world analysis. And the occurrence of, if you look at the past history of cardiovascular disease, almost 28% of the patients had cardiovascular disease to begin with, at the time of enrollment. And if we look at the results those were achieved as compared to DPP-4, the empagliflozin had 41% relative risk reduction for occurrence of recurrence of heart failure, and the all-cause mortality was reduced by 48%. So again, big numbers, they are statistically significant, and this is over and above the benefit that is achieved with DPP-4. So we all know from whatever data we have, the DPP-4s have been shown to be cardioneutral. We know they don't increase the cardiovascular complications except for saxagliptin. And when we see the advantage of SGLT2 inhibitor over and above DPP-4, these numbers are really significant. Similarly, if we look at the renal outcomes, again, if from the EMPEROR reduced data that is we have, irrespective of whether patient was diabetic or non-diabetic, the kidney benefit was also seen, and it was statistically significant in empagliflozin group as compared to the placebo. If we look at the reduction in the prevalence of CKD, when patients had CKD to begin with and without CKD, the increase in the occurrence of CKD was again statistically less in the empagliflozin group as compared to the placebo. So all in all, we know the empagliflozin has got significant benefit in terms of cardiovascular morbidity and mortality. It has got benefit in heart failure, and it has shown to prevent the occurrence of nephropathy in diabetic population. Now, this is a interesting study which was published in Circulation, the EMPA-HEART study, and this study talks about the morphological changes or the structural changes in the left ventricle when patients are treated with empagliflozin as compared to placebo. We all know whenever we are talking about the heart failure, the upcoming pandemic that we are going to face is going to be probably heart failure with preserved ejection fraction. Now, HFpEF is characterized by increasing the LV mass, increasing the diastolic dysfunction, and increasing LA volumes, leading to atrial fibrillation and recurrence of heart failure. So, LV mass index and LV hypertrophy are considered to be the structural indicators of the cardiac functions and long-term outcomes in terms of development of heart failure. So in these studies, the author randomized patients into two groups. For one group received placebo and other received empagliflozin, and when they were followed up for 24 weeks, and when the cardiac MRI was performed at baseline and after 4 weeks, it was found that in the SGLT2 group, there was significant reduction in the LV mass index. So whenever we say that there is a reduction in the LV mass, it means the diastolic function improved in this subset. And when we try to correlate this, follow up these patients and try to correlate with the clinical outcomes, definitely we'll see benefit in terms of the relief in the symptoms of heart failure and improvement in the long-term outcomes. So it was found that SGLT2s reduce the LV mass index. Now, the pathophysiology behind this improvement or the mechanism of action, again, there had been multiple hypotheses. One of them that was proposed was reduction in the extracellular edema. But then, if we see a similar kind of study that was done for the diuretics, it was found, although diuretics did reduce the uh, intracellular or intercellular edema when they were given to the patients, but the LV mass index did not decrease. And diuretic effect of SGLT2s cannot lead to reduction in persistent reduction in LV mass index for as long as 24 weeks. We all know because of homeostatic mechanisms, the change in the changes in the homeostasis leads to again collection of the intercellular edema if there are no better mechanisms. So the other hypothesis that was proposed was reduction in the fibrous tissue in the extracellular spaces in the myocardium, and that was probably explained by the improvement in the cell cytogenetics and reduction in the apoptosis. It was found that when patients were treated with empagliflozin, the structural deformity in the myocytes at the microtubular level was reduced, and there was reduction in the activation of the fibrous tissue, leading to reduction in the total fibrous tissue content in this cardiac myocytes. So this probably led to reduction in the LV masses. Now, from the EMPEROR-reduced trial, which was conducted so as to understand the effect of empagliflozin in heart failure with reduced ejection fraction, irrespective of diabetes. So the typical findings were that the time to first event, the cardiovascular death or heart failure hospitalization, was significantly reduced improved in patients who received the empagliflozin as compared to placebo, and the secondary outcomes were also beneficial. So in total, if we look at the MACE risk reduction with different type of SGLT2 inhibitors in type 2 diabetes, you'll all agree that the EMPEROR is the study which showed significant reduction in the total mortality, and the benefit was not so prominent in other studies like CANVAS, DECLARE TIMI, and VERTICIVI. I mean, if you ask me, it won't be a good idea to compare probably two studies because the enrollment criteria were totally different. The baseline characteristics were different. The severity of the disease in two different studies were different. So it won't be valid to compare all the studies. But I'd like to bring your attention to one important point, that if we try to look at the EMPEROR study and compare it with VERTICIVI, the baseline studies characteristics of even in the VERTICIVI were almost similar to EMPEROR, wherein almost more than 95% of the patients had one or the other atherosclerotic cardiovascular disease to begin with at the time of enrollment. However, the mortality benefit that was seen in the EMPEROR outcome could not be achieved in the VERTICIVI. So this is something which leads us to probably ponder if whether the benefit that is we are getting in some of the studies with SGLT2, whether it is because of the molecule per se or whether it is a class study. Maybe over a period of time when we have more and more studies, we'll be more wiser in terms of comparing and contrasting different molecules, and then probably saying as to whether we can generalize the findings of one SGLT to the other groups, or we cannot do it. Now in this slide, what has been tried to be projected is different studies like EMPEROR, CANVAS, DECLARE, VERTICIVI, and the differences or the benefits those were achieved. As I was highlighting, if you look at the first bar on the left side, the EMPEROR outcome for major adverse cardiovascular event, there was statistically significant difference, but similar difference was not achieved with VERTICIVI. If you look at the heart failure hospitalization, almost all the molecules did show the benefit. So for at least heart failure hospitalization, we may say that the benefit is a class effect. But for the major adverse atherosclerotic cardiovascular events and cardiovascular death, we are still not right if we say that it is a class effect. So we'll have to wait for the further data, and as and when we have more and more data, we'll be more clearer about it. This is all we had been discussing. So now, what does the guidelines say? So if you look at the American College of Cardiology guidelines for heart failure, which were updated in 2021, they have clearly mentioned that whenever a patient has got heart failure, now SGLT2s are one of the molecules which needs to be considered as part of the armamentarium that is used in heart failure management, irrespective of the diabetic status. So even in non-diabetic patients, this molecule, after the Emperor reduced and DAPA-HF studies, these molecules have their role. It has been established. Now the cutoff GFRs from the data that is available is 30 for dapagliflozin and 20 for empagliflozin. Again, ADA probably talks on the similar line. For the want of time, probably I'll just rush through these slides because these have been discussed quite clearly. So in short, if at all I have to summarize, whenever we have a patient with heart failure, irrespective of diabetes status, SGLT2 needs to be considered. Now, where to be placed in diabetic, probably there is no doubt. In non-diabetic, there is some controversy. Still, we are not clear. A recent paper in circulation, the authors dared to say that we should initiate with SGLT2 and beta blockers to begin with, and then add ARNIs and the ivabradine and MRAs, the mineralocorticoid receptor antagonist. But then there is a lot of controversy about the sequencing of the therapy. And I would say, instead of generalizing, it would be better that if we individualize the therapy and use the agents accordingly. In the diabetic population, there is no doubt we'll always consider to use these molecules if GFR permits and patient is euhydrated. So this is we have discussed. Just a last comment about the HFpEF. So HFpEF, we are waiting for the robust data wherein we'll be able to say that this is the molecule, because still we are searching for a molecule which will show mortality benefit in patients with HFpEF. The data we have is with only the symptom benefit, that is also with the ARBs. Now ARNIs in some small studies, and the trials are going on for the SGLT2. So maybe towards the end of 2021 or in early 2022, we'll have the clear analysis and will be more wiser as to how we can treat HFpEF, right? So this is in short about the heart failure cardiologist perspective when we are dealing with diabetes mellitus and prevention of atherosclerotic cardiovascular disease. Thank you.
Thank you, Dr. Rishi. Dr. Shailesh, there is a question. In high-risk ASCVD and DTDM patient, does SGLT2 inhibitor specifically impacted person can be regarded as a first choice of drug?
Sorry, can you please repeat the question? I missed a part of it.
Yeah, in high-risk ASCVD with DTDM patients, can impacted person can be regarded as a first choice of drug?
So as I was saying, I mean, instead of trying to generalize this statement, I mean, what is the indication for which we are considering is more important. Naturally, if I have a patient who has got established atherosclerotic cardiovascular disease, or if patient has got history of old myocardial ejection fraction, his diabetic, his ejection fraction is 40%, definitely I'll consider, I mean, I'll definitely use empagliflozin in such patients, provided the GFR is more than 20 and his U volumic is not dehydrated. There's no doubt about it. If at all, as against it, if I have a patient who has got probably diabetes mellitus, no established atherosclerotic cardiovascular disease, he has no hypertension, he is young, we don't have any markers, high risk markers in him, probably then we have multiple choices, so we can decide depending upon the glycemic levels and all those reasons.
Okay, Dr. Shailesh, you there? I don't think so. Okay, there is a last question. Among the SGLT2 inhibitors, which should be the preferred choice in diabetics with impaired renal function?
So again, sir would have been a better person, but still, I'll take this question by the time.
Yes,
Right?
it's not
Yeah.
there. Yeah.
Yeah. So see, when we say impaired renal function, it is a very crude terminology. So it depends upon the GFR. If at all we have a patient who has got GFR less than 20, probably as of today, the guidelines say we cannot use it. So we won't be scientifically allowed to use it. If at all GFR is more than 20, less than 30, from the evidence we have, probably empagliflozin is the one which qualifies for it. If it is more than 30, definitely we can use dapagliflozin or empagliflozin. Now, depending upon the indications, if at all I have a patient who has got heart failure, irrespective of diabetic status and GFR more than 30, I can use either of them. From the data I have at I mean the data I have. If at all patient has got atherosclerotic cardiovascular disease, no clinical evidence of heart failure, but multiple risk factors, probably I'll consider empagliflozin over and above dapagliflozin because of the benefits those were seen with empagliflozin in prevention of cardiovascular deaths.
Thank you. There is no more questions, so we're concluding the session. Thank you, Dr. Rishi, Dr. Shailesh, for your presentation and sharing your valuable experiences. And on behalf of Lupin, we thank you. Good night. Take care in this
Thank
meeting.
you.
Thank you.
So thank you all. From here, I'm ending the meeting now. Thank you.